Assalamu alaikum. The face is a very important structure. It is your image to the world. And let's see what we can tell you about the face. There are problems in the face. Acne. Acne is a worldwide problem, especially in teenagers, and it affects the skin of the face. But there is a problem of squeezing the acne, and I will address the problem of squeezing in details. There are so many problems and skin rashes, skin diseases in the face. And some people also complain of these black spots in the face. They are called comedones. They also try to squeeze them. They are disfiguring to the face. Again, boils in the skin. Are boils in the skin simple problems? The answer is no. They can be small, they can be large and multiple. And there are wounds in the face, especially for troublemakers, slashing faces of people with knives. Now we want to suture this wound. Now when we suture wounds, we look for the layers and we suture layer by layer. Skin, fascia. The face has no deep fascia. So it's skin, some fat, and then muscles, no deep fascia. Not a nice lesion. It is irregular in shape with the black spots in the middle. This is cancerous lesion. Again, ugly lesion. Irregular outline, different colorations and spots. Melanoma of the skin. Melanoma is a very nasty tumor. Spreads quickly and it is very malignant. Black spots on the face should be looked at very seriously. This is a fungating tumor of the face. That means we need to know lymph nodes draining the face. And I'm sure in your hemolymphatic system you had regional lymph nodes. That's why we study the face. This is a very ugly disease of the face, leprosy. Therefore, it is important to study the lymph nodes of the face. Here is the submental lymph nodes draining the lower lip and the chin. Then we have very important lymph nodes, which are the submandibular lymph nodes, and then the preauricular or the parotid lymph nodes, posterior auricular lymph nodes. All these, they make a circle around the base of the skull, and then they go and drain to superficial cervical lymph nodes and then to deep cervical lymph nodes. This is how is the progression of propagation of these bad diseases. This is a a large lymph node in the neck, superficial cervical lymph nodes. Scars in the face. People don't like to have scars in their faces. Very bad scar in the face. Now, I will leave you with this mind map of the face with the very key words and important information on your e-learning very soon. Now, what is this? This is severe venous congestion of both eyes and eyelids. Now, why is that? The story of this patient starts here. A boil on the nose, or picking a hair from the nose. People do that. Don't play with these hair follicles because they are route of entry of bacteria. And there is what's called the dangerous triangle of the face. Triangle involves the root of the nose, then the nose, then the upper lip. Why it is dangerous? Because venous drainage of this area is going to go to the cavernous sinus. And if the cavernous sinus receives an infection, there will be lots of problems. One of them is the venous congestion of the eyeball and the eyelids. So this is a very bad habit. Let's look at the story of veins of the face. Now, bacteria can go into the veins of the face through different ways, and it reaches the cavernous sinus through several routes. When bacteria go in, like picking a hair follicle in the nose, they will get access to the veins, mainly the superior ophthalmic vein. And the superior ophthalmic vein is going to drain, as well as the inferior ophthalmic vein. They are going to drain to the cavernous sinus. It's a direct way to the cavernous sinus. And I think you know what is the cavernous sinus. It's one of the intracranial venous sinuses that is present on both sides of the body of the sphenoid and on both sides of the pituitary fossa. If bacteria don't follow this way, they go along the facial vein. The facial vein comes from the angle of the eye, going towards the angle of the mandible. Branches of the facial vein, they go deep into this plexus. This plexus is called the Pterygoid Plexus, or veins, around the pterygoid muscles in the infratemporal fossa. And if infection is also in the scalp around the ear, they can reach the pterygoid venous plexus, and the pterygoid venous plexus is connected to the cavernous sinus. Now the facial vein continues down, and the story is well known to you about the veins of the head and neck. Here's the cavernous sinus, and here are the two main roots of problems reaching the cavernous sinus. Now, veins of the face are what? They are valveless, and that is important. That's why bacteria can, or blood can go in any direction. Can this be a case of cavernous sinus thrombosis? The answer is yes. Now, what is this? This is a case of dropping of the upper eyelid on the right eye. The left eye is open, then it's in the center. Now, so the dropping of the eyelid is because a muscle is not working, and that is the levator palpebris superioris. It's paralyzed, which is supplied by oculomotor. And I have shown you some cases where if you lift the upper eyelid, you see the eye is looking down and lateral. Now, so the problem here is oculomotor nerve palsy. Why should the oculomotor nerve be affected? Because it runs in the wall of the cavernous sinus. And if there's a thrombosis of the cavernous sinus, the oculomotor nerve will be affected. The answer is yes, it can be due to cavernous sinus thrombosis. So the story begins here. Mild or mid-face infection, dangerous triangle, okay, or sinusitis. It's also in the mid-face. The patient is going to come to you saying that the most common thing is that they have headache and fevers, signs of infection, and periorbital edema. That is the first thing that makes you think of cavernous sinus problem. Why should there be a periorbital edema? Then cranial nerve signs. Why should we look for cranial nerve signs? Because several cranial nerves run in the wall of the cavernous sinus. We will see that in the future lectures. So that is very important. Some cases, they pass with only focal nerve abnormalities. There's no periorbital edema. If the infection is mild, it affects cranial nerve number 3, oculomotor, or trochlear, and it passes away. Now we should test then the eye movements. Here is an MRI of a normal. That's the pituitary fossa, and these are normal cavernous sinuses on both sides of the pituitary fossa. And here is the pituitary fossa, and these are bad cavernous sinuses. That's how we detect problems in the cavernous sinuses. X-rays don't tell us a lot. So you need to activate your knowledge of the venous drainage of the face, the blood supply of the face, and muscles of the face, because we are going to use it. Muscles of facial expression, probably you you had this information and probably you overlooked and you think it is not that important. But let's have some examples, applied things. This is a lady who had a wound across lower eyelid up to the nose. When we apply our knowledge, the line of the wound is this way. Now, if you are going to suture blindly, what are you going to do? You should identify each muscle and suture it separately. Now we want to test our result of suturing. Here we are suturing part of the masseter, the zygomaticus major and minor and orbicularis oculi and levator labii superioris. So what is going to happen? If this lady is going to contract the masseter, the eyes will be open. A function that is not needed. And the angle of the mouth is going to move. What about this wound? At the lateral angle of the eye, it is here, extending from the orbicularis oculi to the temporalis. If you stitch it blindly, whenever the temporalis is contracted, like in chewing, temporalis muscle is a muscle of mastication, the lateral angle of the eye moves lateral. Now, nobody likes to have such thing. And there are so many examples. That's why we need to know muscles of facial expression. The problem that is going to be solved is that there is no deep fascia, so we can see the muscles. Now, when we suture wounds of the face, we should follow the lines of Langerhans. I saw you a scar in the face running this way. Therefore, it develops a scar. But if it is sutured this way, it is along the lines of Langerhans, and the scar will be less visible. Sensations of the face come mainly from the trigeminal nerve, the ophthalmic V1, maxillary V2. الحضور والغياب أخذ تحيته اللي يطلع خليه. Trigeminal nerve is called trigeminal because it has 3 branches, and the 3 branches, they supply the face. Now, we have a special lecture about the trigeminal, but when we need to talk about sensations of the face, trigeminal is the major nerve supply of the face. I say major because there is a little area, that's the V1, up to the vertex. The vertex is the highest point in the head, and V2, the maxillary, supplies the area of the maxilla and the upper lip, and it goes up to the temporal area, and then the mandibular supplies the lower lip mandible and goes up behind the ear, and there is a little area here which is not supplied by trigeminal. It is supplied by a nerve of the cervical plexus called greater auricular nerve. Here is the distribution of branches of trigeminal. We will come to that later on. That's the ophthalmic, that's the maxillary, that's the mandibular divisions of trigeminal, and here is the greater auricular of cervical plexus. Now these red areas are important because people come and say, I have pain in this area. We should know which nerve is supplying this area. Here is an old lady with a disease called Herpes Zoster. This virus has entered the ophthalmic division of the trigeminal, and you can see that the ophthalmic supplies the forehead, the upper eyelid, not the lower eyelid, and then the nose down to the tip. Again, the same thing. This is herpes zoster of mandibular. This is as if it is drawn by a pen. This is the ophthalmic division of trigeminal. We will be talking about this when we talk about the trigeminal nerve. The face is supplied by many sensory nerves. Face is a very good sensory receptors. And when you study your cardiovascular system, probably you studied arteries of the head and neck, and you need to go back to it because we are going to use it. This arrow is indicating the bifurcation of common carotid artery. That's the external. The external is going to the face and skull. As it goes up, it gives this artery behind the angle of the mandible, and then turns, makes an impression on submandibular salivary gland, and goes obliquely to the angle of the eye, supplying the nose, the upper lip, and the lower lip. It continues as superficial temporal artery, which is going to divide into anterior and posterior branches. So that's the facial artery. Facial artery is going to give inferior labial, superior continues, and then it gives superior labial and nasal branches, and continues as the angular artery on the medial side of the eye. It also gives a large branch that goes into the infratemporal fossa, called the maxillary artery. These two arteries running along transverse part of the face are called transverse facial arteries. Then the external carotid gives one posterior branch, which is called the posterior auricular, that supplies the occipital area. This means what? This means we have very good nerve, very good blood supply of the face. And this means that wounds of the face heal faster. And you make stitches in wounds of the face, don't leave it for 6 or 7 days. It needs less because wounds heal faster. Now, in case of the veins, these veins are valveless. And that is a problem. And we need to go back to them. We are going to use them. This is the superior ophthalmic vein going into the orbit. Then starts as the facial vein, the external facial nasal, then continues as the facial, comparing these branches to the arteries, and then it comes to this point and it joins what? It joins a branch coming from the superficial temporal vein, receiving the two transverse facial veins, and this vein is called superficial temporal vein. It receives the maxillary vein as well, and makes this vein the pink one. Pink one is called retromandibular vein, which is going to divide into anterior and posterior parts. The anterior is going to join the facial, okay, and they are going to join again the internal jugular vein. That goes down to subclavian vein. The posterior branch is going to meet the posterior auricular, and they create the external jugular vein, the vein you see under the skin. So the face has very good blood supply, it has good venous drainage, but the problem is in the venous drainage because these veins are valveless and it has very good nerve supply. These are branches of the maxillary divisions. This is a bad face. When we deal with bad faces, with wounds and infections, we have to have some knowledge of the face. Here is a lady, an Indian lady, which was working in a factory, and she has a long hair. And the factory has machines that have belts, turning belts. Now, she didn't have any precaution about safety, so the hair was picked by the belt. And the belt took her face and her scalp out of her skull. But if you know your anatomy, and if you know if you are a good doctor, you put this face back. This is a few layers on. This is called facial transplantation. Now, several years ago in France, there was a news that people were doing facial transplantation. You know, these people say, I don't like my face. Can you change it? Say, okay, we will wait for a person to die and you like the face, and then we will take the face and put it on your scalp. It's called facial transplantation. Therefore, we need to revise as well facial bones. because we are going to use it. Now, in car accidents and in traumatic cases, the skull and the face, they get fractured. And when we read a skull, what do we see in a skull x-ray? We see lines and bubbles. We see lines and bubbles, and we compare. Here you can see that the left side is not on like the right one, and we can see that the green arrow is pointing at a level of fluid in the maxillary hair sinus. Remember, it's lines and bubbles. Is there an abnormal line here? The answer is yes. Here is an abnormal line. This is a fracture in the face. Here the yellow arrow is indicating at a bubble which is not present on the other side. Tumors. So the face is very important. Don't forget that the face has valveless veins. What do you think this image is telling me? Hair transplantation. What they do is that they go to the area with high density hair follicles and they take a punch group of hair follicles and they come to the front area or wherever there is loss of hair and they implant it there. It's very good business because each punch worth $10 and patients need 4,000, 5,000 punches. This is what a healthy scalp should be. Good hair, no problem. And this is a camera. Dermatologists nowadays use a camera to magnify the area of the scalp. You can see that the hair follicles with hair coming out of the hair follicles. Wounds of the scalp are serious. And we have so many cases of wound scalps. And we have to suture them and admit the patients to hospital. We will know the reason why. This is a case of trauma to the scalp, but the blood which collected in the scalp after a few days went down to the upper eyelid. So the problem here is trauma to the scalp, but then the upper eyelid became a site of collection of blood. This is an image of fragmented hair with healthy hair coming out of its shaft. That's the fragmented hair. Alopecia, loss of hair is a common problem. Certain areas of the scalp, they lose the hair follicles. It's called alopecia. Dandruff, the scalp is full of sebaceous glands. When the opening of the sebaceous gland is blocked, the person develops sebaceous cysts. These are common problems. Then we have black spots. Black spots, they may develop into fungating tumors. Is this malignant or benign? nice outline, no, not very ugly. So this is a benign sebaceous cyst. Severe wound of the scalp. It is bossing, hematoma in the scalp. Again, hematomas. Boxers, they receive severe blows on their heads and develop hematomas. This child, after birth, he had hematoma of the scalp. This is also a common problem. A lymph node behind the ear. Usually ladies or gentlemen, they come and say, I have this swelling behind the ear. It is a lymph node, post-auricular lymph node draining the scalp. So if you comb your hair with a brush or a comb and you injure your scalp, infection gets in and these lymph nodes get larger. That's a hematoma of the scalp that the blood went down to the upper eyelid. Can a person live without a scalp? The answer is no. Now, the American Indians were used to descalp their enemies as an evidence of killing their enemies. If you descalp a person is going to die. Now, we will know why in a short time. Where's the scalp? Is the scalp along the hairline? Some people say no. Anything above the eyebrows. So the forehead is part of the scalp. It extends from external occipital protuberance at the back and nuchal lines to supraorbital margins up to down to the eyebrows and laterally to the zygomatic arch. This is a drawing of the layers of the scalp. It is a skin, connective tissue, epicranial aponeurosis, pericranium, and bones of the scalp. These are the layers. The layers of the scalp are important because some space between these layers are potential spaces of collecting blood. So this is the skin. The skin is thin and it has hair follicles and sebaceous glands. Then subcutaneous tissue full of blood vessels, arteries, veins, and nerves. Then the epicranial aponeurosis of occipitofrontalis. You know, occipitofrontalis has a central tendon. Occipitalis at the posterior and anterior is frontalis, and in the middle there is an aponeurosis of that muscle. Then loose areolar tissue. That's why when we raise our eyebrows, the scalp moves. It moves in this plane. Then there is the pericranium of the bones of the skull. Now the scalp, the skin and the subcutaneous tissue and musculoponeurotic layer, they act as one unit. They are adherent to each other. And there is a loose areolar tissue between this one unit and the periosteum of cranial bones. 5 layers: skin, connective tissue, epicranial aponeurosis, loose areolar tissue, and pericranium. This is a single unit. Scalp is spelled as SCALP. Sorry, I misinformed you. Skin of the scalp is not thin, it is thick. Sorry for that. And it has lots of hair and sebaceous glands. Therefore, scalp is a common site for dandruff and sebaceous cysts. Now let's come to the crunch. This is occipital frontalis. This is a description of the layers. Blood supply. Let's come here. What do we have here? Why should a person with a large wound in the scalp or descalped people are going to have problems or die? It is because of emissary veins. What are emissary veins? Emissary veins, they connect veins in the connective tissue layer. They go through the bones and they end up in dural venous sinuses. And this is a route for spread of infection. So infected scalp wound can lead to intracranial infection of dural venous sinuses. That's why wounds of the scalp are dangerous. Any wound more than 10 centimeters, the patient should be admitted to hospital. Intracranial infection is not a joke. It is a very serious problem. And the loose connective tissue has lots of veins, and there are emissary veins that will go down to the intracranial dural sinuses. These emissary veins are valveless. That's why they are dangerous, like the veins of the face. Very important. Emissary veins are valveless. Now, swellings and trauma of the scalp. It depends on where is the collection. Okay. These are description of the venous connections. This circle is around what? Is around suture. You have on the right skull bone, and on the left is another skull bone. And here is the root of infection. If the hematoma, you pass your hand over the hematoma, if it crosses a suture, then it is superficial. It is not going to dissect itself into the inside of the skull. This hematoma can sag down to the upper eyelid. If it is subaponeurotic hemorrhage or subperiosteal here is the problem. Where is the problem? Problem is that here is a hematoma, and you follow its edges, and for example, it is only over the parietal bone. It is not crossing a suture. That means it is under the periosteum of the parietal bone. This hematoma is going to dissect its way through the suture to the inside of the skull, and it is going to press on the intracranial pressure. That is why you have to know your sutures of the skull very well. Hematomas that do not cross a suture are a big danger, because extradural hematoma will develop. You can find layers of the scalp in any site or any atlas. Therefore, trauma to the scalp and the head are important. Okay? This explains why and how the hematomas who do not cross a suture are important. The morale is learn skull sutures. Now, how do we know that is this hematoma gone inside the brain or not? The answer is CT scans. Here is a small hematoma on the outside, but you can see it has dissected its way to the inside of the skull, and it is compressing the brain. So don't say it's a small hematoma in the scalp and tell the patient, go home, it's going to disappear. No, it can dissect its way into the inside of the skull, pressing on the brain. Now, we will talk about the nerve supply when we talk about the trigeminal nerve. Okay? Thank you.